Soy Esperanza. Quiero contarles que hace 5 años sufro de dolor en la cadera que no me permitía agacharme, girar la cintura, levantar los pies. Estuve en acupuntura, masajes y otro tipo de terapias y no me dieron alivio. Por primera vez fui a visitar al doctor Jacob. Usó una técnica que, aunque un poco dolorosa, me hizo sentir un gran alivio. Llevo 2 meses en terapia y me he sentido enormemente mejorada. Ya puedo dormir por ambos lados, lo que antes no podía hacer. Ya me levanto sin dolor, puedo girar mis piernas y caminar bien. Gracias a esta bendita terapia del doctor Jacob y su grupo de terapistas, porque nos dan una atención personalizada, preocupándose por sus pacientes, dándonos confianza y mejoría. Gracias, Dr. Jacob.
So this is what I did for Esperanza. Esperanza came in with complaints with groin pain, lower back pain, buckling on this side while walking, inability to get up from a chair without feeling like she's going to give way. On further evaluation, we found out that she has 2 problems. One is her lower back. She had L4, L5 pain from there, and a positional fault of her left hip. Flexion was pain-free. You know, it's not a capsular passage of the hip. Is not that. There was no pain with internal rotation of the hip, but there was a positional fault with limitation of hip external rotation. On testing, Faber's test position was positive. She had pain with that. In Ryan's case, he just has a tight hip. But anyway, this is what I did for Esperanza. You throw your belt on to stabilize, to mobilize. I'm sorry. You make sure you push the belt all the way. Have the patient move his furniture away, like Michael says in the book, in the Mulligan book. And then you take your hands, make sure your hands are inside the belt, supporting the pelvis. If you don't actually support the pelvis, what's going to happen is when you mobilize, you're going to draw the whole body away towards you. You're not actually creating a distraction force. Movement mobilization of the hip. Mulligan's technique. This is what we're going to do. Stabilize the pelvis, mobilize the femoral head. So I'm going to apply a distraction force while stabilizing the pelvis. Distract, you see me bending my knees and dropping my butt backwards. And now I'm going to apply pressure over here on the knee and coming back. Remember, it's a pain-free movement. The patient should not feel pain or bring about her symptoms. Obviously, you're going to have some pain. People are very tender over here when you touch. So make sure you always ask, what is your pain? If she says pain is the pain from the belt, the pain from here. You want to tuck in a couple of towels over here and maybe even put a little foam over here, so you know, very sensitive spots over here. So you want to make sure you're safe with that. Make sure the patient does not, your leg over here is not hitting going over the kneecap area, and the patient is comfortable. Once the patient is comfortable and you've protected her, she should be able to do this with no pain, 0 symptom. So that's what I would do to increase the hip movement. Thanks for watching.